Hey, everybody. Welcome back to the Overrun Podcast. My name is Ed Bowder.
I'm Dan Schwester.
And today we are privileged to have an EMS physician from North Jersey. Mike Berkenbush is joining us today. Hi, Dr. Berkenbush.
How's it going, Ed? How are you?
Not too bad. So in our quest to try and solve some of the problems with EMS education, we brought Dr. Berkenbush on today because last year at the National Conference of EMS, he did a talk differentiating different chest pains for STEMI versus non-STEMI. And I thought it was an interesting conversation, so I wanted to get some of that here. So Mike, give us an idea, I guess like some of your background, and we're going to link to a paper you published last year about airways, which is incredible. The work that you've done, the papers that you've published are really important. It's very, very good work. But, and we talked about this off air, I feel like we teach EMTs and medics that chest pain is either a heart attack or nothing. And a lot of it kind of gets lost. So to start, I want your opinion on it. What are your thoughts on this? And then we'll get into, what we can do to fix it, what we can do differently and like that.
Awesome. Yeah. So that's exactly what kind of the gist of the presentation was. I mean, to get the background, I started as an EMT, right? That's actually what got me into medical school. Got me where I am today. I'm still currently work as a medic, so I know how the field works, and of course work in the ER. And chest pain is one of those diagnoses that I think the rough numbers is like 10% of the ED populations comes in for chest pain. Like we deal with a lot of chest pain, and EMS, I think those numbers are probably pretty close. Like this is a very common dispatch, right? Chest pain, something you're seeing all the time. And we kind of set up protocols in order to worry about one of the most dangerous diagnosis, right? We really weren't worried about acute MI. That's probably number one. But there's a whole list of both deadly and non-deadly causes of chest pain that sometimes we just maybe or ignore, or we don't really know the outcomes. So it's harder for us to kind of picture or differentiate, right? And maybe that's really not our biggest role as EMS providers, kind of really getting to the nitty gritty is it costochondritis or is this a PE? But definitely we want to be asking those questions, keep it in mind for sure.
So do you feel that the biggest difference lies in how patients present, or is it a gap in education? Because I feel like as an industry, we focused on chest pain a lot, right? There's chest pain centers. You have national metrics that are, if someone has chest pain or if they have a STEMI, we need to have X minutes from door to balloon and from door to needle. And we have all these metrics in hospital. I don't know that we effectively have them pre-hospitally. So I guess what is a sort of a root cause analysis of how we got to where we are? And then I want to get into, do we think that we can teach this change? Is it a systems thing, an education thing? How can we start, I guess, expanding the minds of our providers?
That's a great question, and can go very involved in this kind of conversation. And in one sense, you're right. There's a lot of metrics in hospital. Just kind of touching on that first, there are some metrics out of hospital now that's expanding. Right, the American Heart Association with Mission Lifeline is really starting to look at chest pain from the pre-hospital setting starting point. Right, and we actually do this with our ambulance program as well. We're looking at aspirin given, different metrics, 12 lead time, notification time to activate STEMI. So I think even the American Heart Association has gradually realized that the pre-hospital piece to cardiac care is really important, and it's a system of care that starts in the field. So I think that's kind of from one sense, even nationally and really beyond that, or internationally, from the American Heart Association, we are getting some recognition from the EMS side that this is a really important piece starting from the field. And yeah, kind of the whole interesting kind of discussion on kind of root cause and how we got to where we are, just looking at how EMS education works, right? We're kind of starting, and it kind of makes sense, right? It's all kind of building blocks. We're focused on certain target diagnoses, and MIs are an important one because we know there's a time-sensitive intervention. The same goes for stroke, really along the same lines, even cardiac arrest, right? These are things where we know there's a time-sensitive outcome, so it's a really heavy focus. And in one sense, by focusing so heavily on these time-sensitive things, which we have to do, we just by probably unintentionally are maybe neglecting a few of the, or in this case, a large percentage of these chest pain patients don't have cardiac disease at all. Right? You can. Right. I think it's also less than 10% of chest pain patients will have actual cardiac disease. So we're in one sense skewing the education to the 10% and not really discussing the 90% of those chest pain patients, which is understandable, right? Because we really got to target those. But I think you're exactly right. It kind of, from an education standpoint, hyper-focused for a good cause, can have some unintentional consequences too.
It almost feels like during the education side where, all chest pain, I feel like for a lot of, especially for BLS providers, we focus on the worst thing, with the idea being, just think that it's worst case scenario, and just, they could be having a heart attack. And that's kind of where we stop. We're like, you don't know enough to differentiate from, anginal chest pain from an actual MI. So assume everything is an MI and go to the hospital. And I feel like that's done a lot in EMS education. And Danny, step in on this too, because we kind of do it with altered mental status too, right? Like if they're altered, they probably are having a stroke. If they're having difficulty breathing, it's probably COPD. And I'm not convinced that casting that wide of a net is an effective way to teach, or even an effective way to practice. What do you think, Dan?
I'm going to kind of take the opposite side on this. And I think we have a lack of education and a lack of clinical skill that we've chosen to give to EMTs, that I don't know that this is a good thing for them to differentiate, except in really, really extreme cases. I think, obviously, if you have sharp inspiratory pain on your right chest wall, I'm pretty good with an EMT saying it's not a cardiac event. On the other hand, some of these things are so vague and we miss so many things. There was a recent paper that just came out that just showed EMS was missing a lot of stroke diagnoses, a lot of things that we focus on. I guess the question that I would have is, how can we do this and make them better and not see a drop off in quality?
And Mike, I think that's probably the bigger question that we're kind of getting at here is, if I'm an EMT, right, I'm going into a patient with chest pain. Obviously I'm not, and we have to be careful not to say that because we're not diagnosing, right? We're just taking our field impression. Right. What are some steps that EMTs can take to kind of, I guess, guide them a little bit more toward, I'm worried that this is a STEMI, so it's going to need, a paramedic unit, more interventions, I have to go to a specialty center, versus, I can take this patient to my community hospital because of some of these presentations. Of course, nothing we're saying is a diaspora. There's, your system is your system, follow your protocols and all the other legal things that we have to say before we get in the conversation.
Right. No, exactly. I think Dan's point is well taken. And that when it comes to life-threatening diagnosis, we cast a wide net and we always want the err on the side of caution. And to be honest, we do the same thing in the emergency room all the time. Like someone comes in for chest pain, even though my suspicion is really low that it's cardiac. Am I still going to do an EKG? Oh, 100% of the time, right? Am I still going to probably order troponin in certain cases? Absolutely, right? So, and it's almost the same. We deal with the same issue. But I think the key, I guess, my key thought process on this is exactly what you're getting at, is the field impression. So, just because someone says they have chest pain, don't stop asking questions. Really try to narrow down a little bit more. Are they having a cough and then have the chest pain, right? Is this pneumonia? And you can absolutely make a field impression with somebody who's really hammering down on your assessment skills. I think that's, to me, the important piece. Like, in the end, may you still need ALS for whatever the reason is, and are you still going to, depending on the scenario, maybe so if you're not sure. And when there's any doubt in your mind, right, you're always going to err on the side of caution. But if they said they had chest pain and then you palpate their abdomen, their pain's in the right upper quadrant, and then the pain start after eating a meal, you might think, wait a second here, this doesn't sound like a heart attack.
What could that be from? I think that's something that we encounter a lot. And, anecdotally, Dan and I have talked plenty of times. How many patients do you get that have abdominal pain that is mistaken as, like xiphoid chest pain? Yeah. Where it's like, okay, but that's literally where your stomach sits. So it's probably something else. And I worry how much of the protocols and the teaching is, you're only as good as the lowest common denominator. Right. So, but I feel like teaching like that sort of dumbs down the rest of education, where it's, if this is the lowest common denominator, then it's chest pain equals MI, off you go. And
that's the classic catch-22 of what we're doing. I mean, right. we want people to be clinicians. We want them to understand things. On the other hand, we give them a limited knowledge base, and we expect them to make a call like that. Like, is it a stroke? Is it bells? You know what? I've messed that up myself. Is it chest pain? Is it cardiac? Is it something else? Is it a female? What other confounders are going on here? I mean, I think we'd have to overhaul the entire system.
Which is probably what we need to do overall anyway. But Mike, I guess go through some of the physiological differences, right? Because we know that men and women present differently. It's something that we talk about a lot in class, but for the uninitiated or for people who have somewhat forgotten, give me some of your points, like your bigger points, where this is a classic abnormal presentation or this is a classic mimic that. I want people to be able to take home something where they're like, oh, I heard this on the show. This is a common mimic of an MI, but it's usually benign.
Gotcha. Okay. Yeah. A couple of them that I can talk about offhand. One kind of more interesting one is pericarditis, which is maybe a tough one to catch up on, but more often we actually did see this some degree post the COVID vaccines and so forth. But just can come out of nowhere. People are having maybe they present with palpitations, some chest pain. But interestingly, the pain gets worse when they're laying down and their pericardium's kind of irritated as laying against the chest wall versus when they sit up and saying more freely and less pain. So kind of positional, and a lot often more younger, let's say younger males per se, not that can happen in older population too. But just kind of, if you see someone who doesn't really fit for ACS, sometimes also pleuritic pain with that. So kind of an interesting
also with something like pericarditis too, they might have an infectious process before that. So, exactly. the story might be, oh, well, I had a cold for a couple of days and now I have this. We might mistakenly think that it's, like costochondritis, like it's a cough, but even something like that, we're like, all right, lie down for a second. Does it get worse? Great. Now we kind of have a better idea of what it is, because usually MIs aren't positional.
Right. Exactly. And it's kind of interesting. I just had kind of a great case of someone who, ended up not being pericarditis. At least, we're not sure exactly. Maybe idiopathic pericarditis, who had like flu-like symptoms a couple days before and showed up actually as unresponsive and hypotensive, and turned out they had a tamponade from pericardial effusion, maybe due to idiopathic pericarditis. So really interesting how that really swung obviously to the severe end too. And that's, I think, the other thing. Yes, there's the mimics, and then there's the other dangerous causes of chest pain that, like aortic dissection. That's a tough one. I'll be honest. There's a couple things to think about. Like if they're saying tearing chest pain right to the back, that's kind of the first maybe usual descriptor, right? But still can be hard. There can be atypical presentation, especially if people are older, not feeling the same things the same way. I've had some really interesting presentations there. Someone complaining of stomach pain, and it was a dissection all the way from the top of the arch, and you're like, how come they're not having chest pain? What's going on here?
Just your stomach? You sure?
Right. Exactly. So that's a tough one. But if you kind of get that tearing sensation, someone probably has a history of hypertension, unequal blood pressures, and look sick. That whole sick not sick situation, definitely one to keep in mind, and not just assume that they're and this is the other problem, right, with the chest pain protocols. If you were doing your assessment, like, wait, this person just doesn't look well. Maybe it's in but maybe it could be dissectional. Why don't we just check pulses both sides? That's an easy thing to do. Blood pressures both sides. And if you gave that patient nitro, you actually could cause harm too.
Right.
If, let's say, they had nitro for some reason, right, and on hand, and that's EMT
and aspirin too, right? You're just everything, like the entire chest pain protocol is going to make them worse.
Right, exactly. So that's the other side of a little difficulty with protocols, it's a tough thing to kind of teach to, but that's definitely one to keep in mind. Also, we kind of mentioned the right upper quadrant pain. I was going with cholecystitis being another mimic, which can easily be. Pneumonia is kind of getting the history, and these days, COVID. Even prior to the whole COVID era, a lot of people just come in with chest pain while they have COVID, more often than not, actually.
Well, and I think that was an interesting kind of thing that people started noticing more during the pandemic, was the kind and the amount of chest pain that coughing can cause you. How often, Dan, have we seen costochondritis in the field, and you get the description, you're like, oh, well, their pain gets worse on inspiration, palpation, and movement, and it's isolated to their fifth intercostal space. Okay, that's almost where you want to have that differentiator. Like there's chest pain, but then there's also pain in the chest, and the two are not necessarily created equal.
That's also where, you start asking questions like, okay, how long has this been going on? I think time frame for me is a big determinant of, do I think this is cardiac or not? Because if you've had this for a week, I think the odds of you having an active MI are pretty low. If I can make the story fit, and that's what I think we need to start teaching EMTs, is if you make the story fit, then it works better.
Right.
Just an isolated symptom, there's so many things going on. But when you add in these other things, when you actually talk to your patient and get the story from them, you're going to find out things that they weren't going to say. You're going to find out that they've had this for 3 or 4 days, that every time that they've been coughing a lot, that there's some tenderness on palpation. That doesn't sound cardiac. On the other hand, you get that little old lady that just doesn't feel right, and she's tired and she doesn't know why, and she usually does everything at home. That's the one I want to sit down and get the 12 lead, and I want to do more of an evaluation to kind of rule out some things. But asking questions and talking to your patients is so important, and it's something we really don't teach well.
That's awesome, Dan. I mean, you pretty much, in my mind, hit the nail on the head. And kind of the whole assessment piece is so critical to come, and then integrating that information that you're getting for the patient and then kind of coming up with their field impression is such a critical piece of education. And it's really not easy to teach, like, how to talk to somebody and how to gather the information without also skewing your information, right? By not first not asking leading questions, like, oh, you're not having chest pain, right? Like, that's not the way you ask it. You say, are you having chest discomfort? Because then they'll say, oh no, I'm not having pain. I'm having that's not pain. That's a pressure. That's a discomfort. You have to be so careful on just language.
Or describing the types of pain. That describing the types of pain is something as a principal question. If you ask the question, if you ask the patient, like, what kind of pain are you having, and they don't understand the question, it's fine to clarify. But if you ask, like, would you say that your pain is burning, crushing, stabbing, tearing? Like, given those options, the patient is going, you've conditioned them to answer the question. And a lot of times patients will think that there's a right answer. So you'll, is your pain a certain type of something? And a patient might say, well, I mean, I guess it's tearing, but you leading them in that question is now taking you down a diagnosis path that is just incorrect. Based off of our own biases. And I think that we have to watch out for confirmation bias as well, where, you walk up and you're like, I think you're a heart attack, so I'm going to make sure that everything fits heart attack. Until proven different thing, but taken to the wrong end.
And that's one of the things we've got to teach, the open-ended question, the classic, what's bothering you today? How long has this been going on? What does it feel like to you? And let them explain. And again, good point you made with using pain over discomfort or, not feeling well, because they don't qualify as pain. Women don't qualify as pain.
Right. Yeah, I think the open-ended point is great. Like, we're already skewed by dispatch, and I got the same, like, EMS or ER, like, you're skewed by what your chief complaint is. And instead of saying, how's your chest pain today? Like, exactly what you said, what's going on today? And sometimes you're led down a completely different path when you just let the patient kind of explain what actually symptom brought this on, and not just what somehow the dispatcher got from Pro QA, which can be vastly different, as we know.
Sure.
Anyone doing EMS knows that. So just kind of, like you said, just getting some open-ended, you let them talk, and then you got to kind of hone down that in a non-biased fashion. And sometimes you're not going to come up with an answer, right? There's some days I don't know which one it is, but at least get a kind of your risk in mind. There's still risk here for an MI, then we're going to treat it as such, and that's okay. Absolutely.
And it's perfectly fine that, sorry, go ahead.
No, yeah. Or it could be the contrary, where, like, I have all this information is really pointing away from my MI completely, and this is clearly, like, I don't know, pancreatitis or something, right? Like, they're alcoholic and they're drinking. There's so many different ways to look at it.
Yeah, I've done that to patients too in the back of the truck. I'll sit there and go, look, honestly, I don't think you're having a heart attack. However, that's the most dangerous thing that it can be, and I'm going to treat you for that because I want to make sure you're safe.
Exactly.
Yeah.
And when the doctor tells you it's something different, I just don't want you to think I'm an idiot. I'm just protecting you.
Exactly.
I think that's an EMS. That's what we should do.
Exactly. And I think that's a great way to actually, that's a great conversation to have with the patient. Like, we're not really sure, or like, this is what we kind of think is going on, but to be safe, here's what we're going to do. And that's a great way to explain it. And that's also doesn't set us for a failure in the ER where they do get important perspectives from EMS. And sometimes we don't really get to appreciate this, but what you say to them does have an impact on how they expect their care to be down the road. And I've had that numerous times where it's like, well, the EMT said on scene that maybe it was this, or the paramedic said this, and so it can be skewed sometimes in wrong directions or right directions, right? It can go both ways, and that does play a role on what they're anticipating down the line. So that definitely is meaningful.
And I think the honesty with your patients is an important thing that's missed too. I mean, I've told patients like it looks like you're having a heart attack. So
Yeah.
this is what's happening. When we get to the hospital, there's going to be a bunch of people who are going to ask you all the same questions. They're all very excited to see you, and there's going to be a whole bunch of other stuff that's going to happen. And similarly, if you're not sure, like, listen, there's a bunch of things that this could be, but in the end, we're going to have to go to the hospital to find out what it is, one way or the other, right? And I think that's kind of the most important thing is that, you know what, you have your clinical gestalt that we've talked about a lot. You have your thought process, your treatment options, your hospital options. You're always going to want to err on the side of the patient. This is more of a conversation where, we don't want people to think that, well, every chest pain is a heart attack until proven otherwise, because that's what my protocols say. And it's like, no, there's so much more nuance to it that, and you could, if you want to err on the side of caution and every chest pain's an MI, great, fine. But you're going to find that a lot of those patients aren't having MIs. I can say anecdotally, and I feel like there's data to support this, but I could be absolutely wrong. Women typically don't present with pain. They usually present with shortness of breath or, like an ache to their back and fatigue. And that's just generalized, right? So walking into a female patient who's complaining of chest pain, you don't want to just disregard their complaint or their pain and say, nah, it's not a heart attack, right? That's that full assessment that we've talked about. But just as much as you want to have kind of the idea in mind that this patient could get a lot worse, you also kind of want to have the idea in mind that this patient might not be as sick as maybe I want them to be.
That's a fair way to look at it. Yep.
So one of the things that has kind of, and this is just a fun question before we wrap up, Mike, do you feel, I have two things that happen in the field, and I just want your opinion on them. For point of care troponin, I want to know if you think that there's a value to paramedics or EMS in general doing point of care troponin. And I want to know if you think there's any value to EMTs learning how to either read or understand cardiac monitors and EKG strips.
That's both interesting questions. And being
we like to have fun, Mike.
Yeah, this is awesome. I guess I should let me clarify this a little bit. So, in one sense, as working as a flight physician at Wisconsin, we actually carry an EPOC device, which is basically like an ice. For those more familiar with iStats, it basically includes like maybe 15 components to that. Troponin doesn't have to be one of them on a helicopter, but that's usually not flying directly from the scene so often. Undifferentiated chest pain. But do I think it'd be an interest? I think as this, I mean, I'm sure you guys talked about ET3 and this whole model of care gradually changing over time, which I mean, obviously ET3 itself maybe not be the end result model, but
it's a whole other show.
Yeah, exactly. That's a whole nother, we could go on for a little time there, but just the whole, I mean, clearly we're doing problems with overcrowding in the ER. The gradual shift to more advanced EMS care is kind of continues to happen over time. I could see a role for an iStat troponin in specific instances for sure. There's been some studies on this. The one problem is always going to be onset of pain, right? So if the pain just happened, the first troponin is basically meaningless. So that's the biggest problem. So if the pain is new onset prior to calling, the iStat troponin is a useless test in my opinion. And I've had this with STEMI patients with a normal troponin when the first one. You need the 3 hours. So there's nothing you can do about that. That's hard. Now it's a person who had chest pain for over 12 hours, a negative troponin.
who's now really out of the window and can't be treated.
Yeah, negative troponin at that point is really predictive of no cardiac ischemia. So there's benefit. Right. Now the real question is, can you avoid ED visits with this? With a specific medical directed protocol, I think it could be crafted, and I would be for it. In specific, you have to obviously set up a whole bunch of guideline, a framework for how this will work, what type of patients, probably be a med control kind of discussion for release, but could you do it? I think absolutely. It would take a lot of education to work and probably some protocolized and medical director piece so that we can have the input of this is what I think is going on and talk to the medical control of the phone. Like, look, here's where we're at. This is kind of atypical with no risk factors, maybe a lower age, right? All things that say this is a low risk patient. And then ideally you'd want to be able to also find out ways you can follow up with cardiology. Here's referral, ways to do this, maybe with telemedicine. There's different ways to kind of integrate it, but I think we got a little ways to go. That would be awesome. As far as iStat troponins go. As far as the 12 leads, so someone was just showing me these kind of new apps that are even obviously we know the readouts on 12 leads are bad, right? So interpreting them is always kind of a bone of contention and how that's done. A new apps that can predict better than
they work well. They wouldn't lie to me.
You're right. So
Computers always.
As AI progresses, maybe this ends up being more and actually pushed to the BLS level more than we currently do. Because really, there's, I mean, you can argue AI is probably better than me right now. I'm sure already. There are AI programs that are great. So there's that piece to it. So I do think that has high potential to expand, probably with the conjunction of an AI. I mean, there's a lot of systems that are maybe not so much in New Jersey, but allowing are more in the country, allowing BLS to do 12 leads and then just sending to the hospital or the cardiologist. So that's no matter what I say from the ER's point, the cardiologist is still not going to wake up out of bed unless he sees EKG in a lot of cases. So there's always that piece of how do you get around that. But having the acquisition in an area with potentially poor ALS coverage or missed ALS calls, or whatever the case is, where you're having enough where you can make a justification for doing the extra trainings. I mean, putting on the EKG is not that hard. And getting the technology to make it useful. I mean, over time, I think that'll be coming down the line also.
Well, that's what I think is interesting about the EKG conversation is, there's the technology aspect or technologists aspect where, you have to read it, interpret it, but it's also just kind of a picture that you can send on to the receiving hospital. So I'm interested in the AI thing. I think that's very interesting. But Mike Berkenbush, EMS physician from North Jersey, our home, thank you so much for joining us. We'll be right back after this. This episode of the Overrun Podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show. All right, welcome back to the Overrun Podcast. Thanks to Mike Berkenbush for appearing on our A segment. And Dan, that was a really good discussion. I feel like we kind of heard a lot and learned a lot that we hadn't really thought of before.
Oh, absolutely. Just something, a mundane bread and butter call like the ones we get all the time. How many different facets are involved and how much we really don't know. Dunning-Kruger is alive and well.
Boy, is it. And I think that one of the things that one of the reasons we wanted to get him on the show is, we're dispatched to chest pain a lot. Like it's, altered mental status, chest pain, it feels like kind of automatic. And generally speaking, it feels like I guess the thought, the ethos is that any chest pain could be a really serious MI. And thus we should send everybody, send the medics, send BLS. And I, at a fundamental level, I understand sort of the onus behind that, but I almost wonder if that's where our problems with over triaging start is, if we start in the classroom and say, you should just, as an EMT, you should just assume that every chest pain is a heart attack. I understand why we teach that. It feels like almost laziness at some point where instead of teaching, differential pathology, we're just saying, chest pain equals heart attack. And that's what it is.
Is it laziness or is it we're not confident in our students and we're not confident in our own abilities to ask these questions and be confident in the story we get?
That's fair.
Yeah. I wonder if it's that. I think there's a hesitance, and I think it's very easy, especially for an EMT level BLS clinician to go, and it's chest pain, go to the hospital, gets a cardiac workup. And
right.
They're fundamentally right. As Dr. Berkenbush said, the vast majority of these people are at least going to get a 12 lead and a troponin level,
sure.
just if not for a rule out. But there are questions that we can ask in the field that can really make a difference to the pathway that patient makes through the emergency department. That was the big takeaway I took from him talking to us, was how much he really depends on the report from the field provider about what's going on with the patient. What did the patient present with? More importantly, what did you find on your assessment that he needs to be aware of? We tend to think of EMS, and it's very fashionable to think of us as kind of a pirate band that we're, that nobody listens to us, nobody cares. We're like Philadelphia fans. And
hey.
Well, you guys have the song. I don't.
I mean, well, listen, shout out to Travis Kelce, our fellow podcaster, for coming up with the best song for Philadelphia fans ever.
But getting back to it,
Jason Kelce, not Travis Kelce. It's Jason Kelce here.
Taylor's boyfriend.
Can't imagine how I confused the two of them.
But I think that was a good takeaway for people to understand that they do listen to us. They are
Yep.
interested in what we found and what the story is. And we should take advantage of that. We should try to get that information and have that delivered to the emergency department so that patient gets a good, accurate trajectory through the emergency department and to whatever definitive care they're going to get. I know we made a comment that we don't diagnose, and we do that with air quotes. And no, we don't come up with definitive diagnoses that people can leave and say, well, I had this, except in very rare circumstances. But we do diagnose. If you're giving medications or prescribing a treatment for something that you think is going on with the patient, that's a diagnosis. It may change.
Yeah,
I think still diagnosing.
I don't know. We spent a long time, as an industry going over like, is it a field impression or is it a diagnosis? And like, it's a semantic argument that I think like it wastes time, right? We spent a long time in New Jersey arguing over whether a certification is tantamount to a licensure. And it's a semantic difference at some point. But, and again, I'm not just disparaging the licensure approach in New Jersey. I think it's probably better. But at some point, undifferentiated chest pain can probably be differentiated in the field, right? Like I don't think we teach EMTs about costochondritis. I know we don't teach them about pleurisy. We don't spend a lot of time going into, we talk about pneumothoraces, but we don't really go into them. We don't really talk about pericarditis. We don't really talk about endocarditis. So I can appreciate the approach, right? And I wonder if there's so many possibilities for what chest pain can turn into or what chest pain might be. If we're talking about like casting that wide net, right? Like, well, we might as well treat it like an MI. And then if we're wrong, at least then we treated them the right way. But I feel like there's so much in the thorax that can cause problems, can cause pain, can cause whatever, that it would behoove or benefit EMTs to know like, all right, there's musculature in between the ribs. So if someone is, for example, a smoker, specifically like a smoker in their 40s, 50s, whatever, and they have point tenderness in between their ribs, that's probably muscular, right?
Yeah, no, that's there.
Like, and again, I can appreciate the whole like, well, what if it's not? But I worry that there's been a lot of teaching that's been done by people who are like, well, one time I had someone who, I had a 93-year-old who complained about being thirsty and she had an MI.
Right.
So, but I don't assume every 93-year-old is having an MI if they have kind of an abnormal complaint. But I think we have to have this balance of having a high index of suspicion, but also having a really effective assessment to try and see, what works.
Yeah, and that's going to come from learning, and it's on the individual clinician to do this. You only get a certain amount of information when you graduate your program, whether it's EMT, paramedic, whatever. It is the basic tools for you to function at your capacity. That's it. You get to learn a lot more by learning and doing. And part of this stuff is skills that you're adding to your toolbox. When you assess somebody and you find out that it's not a heart attack, or that it was costochondritis, go back and find out what made them make that call. What was the decision points? I go back and follow up on my patients as much as I possibly can. A fair amount of times, I'll tell you, even being in the job as long as I have, I'm still surprised. I get things like, oh, that was that? Wow. How did you think
and that too, huh?
How did that happen? And I will say that. And, as long as they're not knee deep in something else, most nurses, most doctors will talk to you and share the information. And especially your docs, they do enjoy teaching. I mean, there's a few that are real just, grumpy gooses, but, for the most part, this is all stuff you're going to learn down the road. Like, we don't teach, for example, with strokes, we don't teach Bell's palsy when we're teaching EMT students strokes.
Right.
We should.
Or, I mean, it's I can say like I've made sure to teach it in classes that I've taught, and I know you have as well. But it's not a curriculum thing. Is really the problem.
It's not on the differential. It's not expected, and it's something that's out there and it exists. I had one 3 months ago. It was there. and
Mhm.
yeah, we stroke alerted it, but I was like, I'm not sure. I don't know. Something's not right here. And the doc's like, it's bells. I'm like,
Yeah.
wow, how did you? So tell me what I missed. And he goes, well, it's this, and here's a point, and here's a pearl. And I was
Yeah.
like, great. Now it's in my toolbox.
And the easiest thing with something with bells, because it's the difference between an upper motor neuron and lower motor neuron injury. If you're not sure if someone's having a stroke or if they have bells, have them raise their eyebrows.
Stroke
If
spares
they
the
can crinkle,
eyebrows.
if they can crinkle their forehead and they're still having those signs, it's a stroke. If they can't crinkle their forehead, they have Bell's palsy. And again, I'm sure someone somewhere is like, well, what if they have Bell's palsy and a stroke? I'm like, all right, well,
Yes, and
then treat it as a stroke. Yeah.
and an asteroid could hit,
Right.
like
Exactly.
tomorrow.
Yeah. And yeah. But so when assessing these chest pain patients, I feel like people are worried that they're going to get in trouble if they don't, try and STEMI alert it, or if you're an EMT and you're worried that, I didn't call medics or I canceled medics or whatever. I think there is a very significant fear of, litigation and lawsuits and whatever. And again, we're not lawyers, so enough, that there's that disclaimer. But it occurs to me that as long as you're acting in the best interests of the patient, you'll probably be fine. But you can apply your clinical gestalt and that knowledge to your assessment of the patient, right?
Mm-hmm.
So, my patient's got chest pain to the left lateral side, right around here, around like the third, fourth intercostal space. If you're an EMT and you're going through that assessment and the patient's skin is warm and dry, they're talking to you in full sentences, they're normotensive, they're normocardic, right? There's no other like outlier type of presentation. Odds are, if like, because we talked about before, right? If it walks like a duck and quacks like a duck, it's probably a duck, right?
Oh, yeah.
And that can be muscular pain. Pain that's reproducible on the assessment is almost always muscular. Now, again, nothing we're saying is a diaspora, right? Nothing we're saying is holistic. There's always going to be outliers. There's always going to be, the one provider that you worked with who's like, well, one time I had a patient who was having a heart attack and they had reproducible pain. And, this way, every reproducible pain might be a heart attack.
We should never, ever, ever look at anything else.
Right. And I don't know that that's true. Now, and again, this isn't to discourage people from going to the hospital if they have chest pain, or an EMT assessing a patient as an MI if they have chest pain. It's more, at some point, it becomes a resource allocation thing, right? Where, we already have a shortage of EMS providers. We already have a shortage of medics. So it is going to fall into the purview of BLS providers to do these, kind of really well done, thorough BLS assessments and realize, okay, this patient is probably not cardiac pain. Now, again, you can be wrong. And I want to reinforce too, like, it's okay to be wrong.
Mm-hmm.
Like medicine's a practice for a reason. Right. But in that type of setting, you don't necessarily have to worry about, your job security or being so worried about getting a chart kickback, which again, I think as a culture, we kind of make chart QA tantamount to discipline, which is not the case in a lot of plaplaces.
I think we worry about a lot of things in this job that we probably shouldn't, and we don't worry about things that we probably should.
I think it's probably right.
Look, there is nothing wrong as an EMT with like Dr. Berkenbush said, ask the questions.
Yeah.
Make a determination based on what you see. Does that mean that person's not going to get a workup for a rule out cardiac? Not necessarily. It just means that they're not going to get that immediate full court press. Is that good for the patient? It's probably what the patient needs. Most patients generally fall to getting what they need. It's not, but here's a hot take that I'm going to take from this before we move on is EMTs are going to have to start realizing in this world that even though you're just an EMT, and I put that in air quotes, right, we are going to expect you're going to be expected to know more and to be able to apply more and do more than you've ever done before, simply because of the nature of where this industry is going. We have less people coming into the profession. There are less people to serve the community. More people look at it as a quick stepping stone. Turnover is enormously high. And the clinicians that we have on the road today are going to be expected to know more. It's going to be the way it's going to be. And these are tools that you can start putting in your pocket and in your toolbox and using in the field. And for the vast majority of people, you're going to be doing better care for your patients.
Right. And again, something that we didn't really talk too much about is finding the right center to take that patient to.
That's going to be huge.
You know, if you have a cardiac center that's near you, that's something that you need to consider.
And the future of that's where the future is going, let's be honest. And that's what the future is going to be. And that's where you're going to make these determinations that maybe you will not have an ALS provider available for you for this call. Maybe that warrants taking the person to the cardiac center because you've got a suspicion over the community hospital that doesn't have PCI or have cardiac surgery. Those are going to be the determinations you're going to have to make. And how are you going to do that? Clinical skills, your clinical exam, your gestalt that you're going to apply and say, what am I really seeing here? What's behind it? What could it be?
And, we talked about getting to know the staff and like that. And there is a reality that the more you know the staff at your receiving facility, the more you interface with them, the better you get to know them, the more the staff is going to understand how you treat people and how you respond to things. There's an unfortunate reality that knowing the staff is going to make the patient get treated better simply because you personally know the staff, as opposed to walking into a strange hospital. But again, that's where you have to kind of not necessarily be forceful, but you have to say like, listen, I have a patient who's sick. I don't know what's wrong with them and they need to be fixed, right? They need to be treated. So there are some variables within the hospital that are kind of tough to get around. But let's get into our final thoughts for this because we've been talking about doing this episode for a while. So your final thoughts, Danny, on chest pain for the BLS provider.
It's something that you need to learn about. It's something that we need to put a lot more effort into looking at the differentials. Not every chest pain is cardiac. Not every cardiac is chest pain. It's comes down to you as a clinician seeing your patient, putting hands on them, asking the questions, getting a good history, and applying what you know to that to come up with a decision that's the best for the patient. And if you do that, you might make mistakes down the road, but you're not going to be held as someone who didn't do the right thing.
Yeah, I think that's right. Again, as long as you're acting in the best interest of the patient, there's really not a lot to be worried about. But I do think taking that 5 or 10 minutes during your assessment, right? And okay, when did this chest pain start, right? Did it start acutely? Has it been going on for a while? Does anything make it better or worse? And trying to figure out where the actual, the nidus of that pain is, whatever the causative factor of that pain is. And an important question that I don't know that we ask enough is, and this is all stuff that goes back to the sample history that you get in EMT school, right? The last thing, what were you doing before this started? Mm-hmm. And there's concerns in what you were doing before this started. So let's say you have someone who is lifting, right? The pain that you're having in your chest, did it start like right after you bench pressed 240 pounds, 3 sets of 12? Right. Or were you sitting at home where it's more of like an unstable angina type of presentation where the patient was just sitting comfortably and then suddenly the pain started? Because those are two very different patient presentations. Right. And they're two
very. The first one I'm not really interested. The second one I'm a little bit interested.
Yeah. And the first one, it's entirely possible that you can, throw a clot and have an MI while you're lifting weights. There's nothing to say that doesn't happen. But again, looking at the entirety of the picture.
But I'm not looking at a healthy weightlifter who had no history prior to that, felt a sharp pain when he was exercising, and on movement he has a problem. I'm not looking at that as cardiac.
Right. And the story makes sense, right? He didn't have any pain. He lifted in a group that specifically targeted his chest muscles. Now he's got chest pain, right? That all adds up. When a patient is telling you a story, you're like, well, I was sitting here and I was watching, cartoons or whatever, and then I started developing chest pain. There's no explanation for that chest pain.
A little more. Right? One of the things I really like too is the associated symptoms, because I think to me that's just a red flag. If somebody gets the chest discomfort, and I use discomfort instead of pain because a lot of people go, well, it doesn't hurt, it's just pressure.
Yeah.
But if they got nauseous, if they got sweaty, if they got sick to their stomach, if they got dizzy, if they felt like something wasn't right, if they just got a really bad feeling when this happened, That's got my attention. Those associated symptoms.
Acute onset of general not feeling well is always something that is kind of a red flag for me.
Until proven otherwise. Now,
no,
both
I
patients,
think that's right.
Am I putting a 12 lead on both patients? Probably.
Yeah.
I mean,
but again, the need for a 12 lead doesn't necessarily denote, the need for a 12 lead doesn't necessarily denote the need for a medic unit.
Right.
But I do understand the differentiation.
Right. But, if I'm there and that's in my scope of practice, the guy who's getting the weightlifter, I'm still going to do one because if it comes up normal, it's more evidence that tells me I'm on the right path.
Yeah, that's probably true. But again, from the BLS level, if you can't
from a BLS
provide a 12
level,
lead,
you can't do it. I think you can still make that call pretty confidently.
And so the biggest thing is that we have to look for is just, do the proper assessment, find out the story, figure out what happened with the patient. Chest pain is something that it's our bread and butter. It's one of the things that we deal with all the time. And it's very important that you're able to assess these patients properly. If you're concerned about their heart, you want to see what the heart looks like. Is the heart beating too fast? Is there too much pressure on the heart as reflected by the blood pressure? You have to know what the actual muscle of the heart is doing. And if the muscle of the heart shows that it's fine, normotensive, normocardic, then maybe you go down a different treatment algorithm. But there are a lot of things that we need to take into consideration. So thank you all for listening to this episode. For The Overrun, my name is Ed Bowder.
I'm Dan Schwester.
And make sure to subscribe and follow us on YouTube, which is where we're doing all of our shows now. And we will talk to you next time.
See you later.